Just want to welcome everybody to to our Zoom webinar on shoulder arthritis and replacement. We're going to go around the room real quick and introduce ourselves, and then we're going to get going. I'm Dr. Ryan Smart.
I'm Dr. Dave DiStefano.
Dr. Nate Everding.
Brandy Brown, PT.
All right, we're going to get right into it so we can get through our slides, and then hopefully have a chance to ask some questions or answer some questions. All right. So just the introduction about shoulder arthritis, it's actually very common, the 22 million people. And then the rates of shoulder replacement and joint replacement are increasing. Obviously, I think most people are familiar with knee and hip replacement, but you can see from the year 2011 to 2017, shoulder replacements are really on the rise. And I think we'll discuss a little bit why we think that may be. And then it's projected to even increase further over the next bunch of years going to 2027. So very common. You can see, obviously, as I always say, you don't walk on your hands. So knee and hip arthritis is far more common on that bottom right graph, but shoulder arthritis is there and replacements are becoming more common. Just a little bit about the anatomy of the shoulder. It's a pretty complex joint just because it has such extreme range of motion, but you have the arm bone, which is called your humerus. And then you have your scapula, which is basically your shoulder blade. And that's a really big bone that ultimately becomes the socket of your shoulder. And then on top of the shoulder, you have your clavicle, also known as your collarbone. And there's a lot of articulations that happen there. The glenohumeral joint is actually the shoulder joint itself. The acromioclavicular joint is a small joint that lives above your shoulder. And then your shoulder blade, how it sits against the rib cage is known as the scaphothoracic joint. And all these joints play in. And I think when we see patients in the office, a lot of times you have pain in different spots. And I kind of tell everybody it's because it's all related. Looking at the shoulder joint specifically, you have the ball part of the joint, which is known as the humeral head. And then the socket is known as the glenoid. And that socket, the glenoid, actually is the same bone that's the scapula. Again, just a very big bone. We think about it as a golf ball and a tee. Unlike a hip joint that has very deep, bony socket, the socket of the shoulder is very flat. It's like a saucer dish. So it relies on all the soft tissue attachments, which namely are the rotator cuff tendons, which I think are probably one of the more confusing things for the layperson. And it's just a funny name. So the rotator cuff itself is a series of four muscles that come off the shoulder blade that go to the ball of the socket and become tendons. And I always describe it's like strings on a puppet. So when a certain muscle fires, depending on which tendons attach, it's going to make the arm move in certain directions. So these four rotator cuff muscles go to four separate tendons, and they really allow the shoulder to do a lot of the extreme motions it can do and help stabilize the shoulder itself. Arthritis, again, also a confusing thing. Arthritis is wearing of the articular cartilage that lines the end of the bone. And it's just like a tire. Normal shoulder would have a tire that has good tread, and arthritis is wearing through that tread where you get a bald tire, basically. And there's multiple types of arthritis. Probably the most common one is known as osteoarthritis, or just generally thought of as wear and tear arthritis, and that's where you lose your joint space. So when we take x-rays, I know a lot of people always ask, why are we taking x-rays? Well, we get them because we want to look at bone, and they really give us the best look at arthritis because we can see if the joint space has been narrowed. That's an indirect finding that lost cartilage. And then you can get bone spurs that form, which are almost like barnacles. And then the head, instead of being flat or being a ball, kind of rounds off and flattens. And then you have a lot of decreased motion. In arthritis in general, it kind of wears out the back of the shoulder more than the front, which is somewhat of a detail more for us surgeons than patients. And then a small percentage of pure shoulder arthritis is associated with rotator cuff tears. But interestingly, the vast majority of purely arthritic shoulders don't have rotator cuff tears. They're just arthritic. If you look at this picture, again, this is X-rays. In the picture on the left, you can see there's a space between the ball and the socket. This is so I'll just see if there's a laser. I don't think there's, but the one on the right, you can see if you compare the two, there's complete destruction of that joint space. So that's how we know when we get an X-ray that you have arthritis in your shoulder, and that's regular primary arthritis. There's a unique arthritis called rotator cuff tear arthropathy, and that's an arthritis that forms when somebody has a chronic rotator cuff tear. So when those rotator cuff tendons are torn and they're not doing their job, which is to stabilize the ball within the socket, the joint wears abnormally and can lead to this form of arthritis. And a lot of times we can see this on X-ray. They're subtle findings, but the X-ray on the right shows the ball is basically meeting the roof of the shoulder, which is called the acromion. And pretty much any surgeon that sees that knows that the rotator cuff isn't working well. And a lot of people, and I know we'll get into details about regular replacements versus a reverse shoulder. For those of you out there who've heard of a reverse shoulder, this is one of the main reasons you would get a reverse for this kind of arthritis. Exam-wise, a lot of times we'll see swelling, which is an effusion. And then patients will have, if this gets really bad, they almost have no ability to raise the arm at all. And when we examine them, there'll be a lot of lags showing us that the rotator cuff tendons are also not working at all as well. Arthritis after prior surgery can happen. A lot of people in their younger years will have shoulder instability. They've had surgery where the surgeon tightens up the shoulder. Particularly in the old days, they would really tighten up shoulders, and it stabilized the joint at that time, but it also led to pretty severe arthritis 20 to years later. And this actually can be one of the toughest arthritic conditions for us to deal with, because from a surgery perspective, there's a lot of scar tissue. Patients had prior surgery, and this is a special conversation if somebody's had this type of surgery, where the replacement sometimes can be tougher, there can be more complications, and sometimes you need the reverse shoulder rather than a regular replacement. Rheumatoid arthritis and inflammatory arthritis, we don't see as much bad rheumatoid arthritis as I think maybe 20, 30 years ago, because of the medicines that are used to treat rheumatoid arthritis. But on X-ray, it'll just wear differently, where the joint kind of medializes, which means goes more into the chest. You don't have as many bone spurs, and the soft tissues are very inflamed, because rheumatoid arthritis is primarily an issue of the synovium, which is the soft tissue lining of the shoulder joint. Chondrolysis, this is kind of again, we don't see this that much anymore, but it would be more of an arthritic condition in a young person. Sometimes the joint rapidly wear, can be related. In the old days, when you had shoulder surgery, you get a catheter, which is like a plastic tube placed in your shoulder after surgery. And that medicine was at that time and later found out to cause cartilage wear. So that's just a unique form of arthritis. As far as non-operative management, it really depends on the patient's age, type of arthritis, and then quite frankly, how bad it hurts. I think all of us would agree that the main indication to do a shoulder replacement is pain. That's what we're really good at making go away. If the pain is tolerable, a lot of times we advise to do non-operative treatment, kind of live with the shoulder as is. But when the pain gets to the point where you can't tolerate it, it's waking you up at night, making life miserable, that's when surgery is indicated. As far as non-surgical treatments, there's physical therapy, there's medicines, and then we'll briefly discuss biologic treatment. Non-operative treatment in the form of physical therapy is a worthwhile endeavor, because you're really trying to keep and maybe slightly improve the motion you have, and then strengthen the joint. You don't want to keep losing function and keep losing motion, because that tends to make arthritis more painful, basically. As far as preoperative therapy, I mean, again, it's as far as the being an absolute necessity, not always, although I would argue insurance is going to want you to do this prior to any surgical intervention, but I think most of us would recommend it. There are at times, however, therapy, just like any arthritic joint, if you're making it work hard, sometimes you can develop pain. So there is a give and take there as far as doing physical therapy. As far as medicines go, there's medicines we prescribe. Most people are familiar with Advil, ibuprofen, Motrin. Those are called non-steroidal anti-inflammatories. They can help decrease the inflammation and the pain associated with arthritis. However, most people don't want to live on medicine forever. There's topical medicines like Voltaren gel, of course, the over-the-counter like Bengay. They can help. They can sometimes just make it not hurt as much, but aren't incredibly effective. Cortisone shots. Cortisone is a steroid that decreases inflammation. So it's the pure indication to do it is to reduce pain. It's not going to really improve really function unless the function is limited by some of the pain you're having. Then sometimes you may see brief improvements. But it is limited. It's not particularly healthy for the joint. It's not great for cartilage. It's not good for the rotator cuff tendons. So it's something I think all of us do far less than we were doing probably 15 to 20 years ago. Pain medicine, opioids, not really recommended, right? That's the problem with opioid painkillers is your body gets used to them. So if you take them after a period of time, you just need more and more medicine. So that's not really recommended. I know a hot topic that a lot of people may have questions on are these biologics, platelet-rich plasma, that's PRP, and then there's stem cells that are the BMAC and these adipose. They're I would say all of us agree it's a great idea. It's a great in theory, but the proven efficacy is not really there yet. Is it the wrong thing to do? No, but it's not covered by insurance. All of them come with a cost. I think a few of us are doing PRPs in the office. That's where you draw blood, you spin the blood down, you siphon the platelet-rich plasma off, and you inject into the joint. So I tell most of my patients it's not necessarily the wrong thing to do. If you have severe arthritis, though, it's a mixed bag. It's probably more likely than not that it's not going to particularly work well. I don't think anybody in SOS is doing stem cells. That's where you have to get cells either from bone marrow or from fatty tissue and then try to inject it again. The literature isn't really there. I mean, I think it's an exciting thing. There's parts of the country that are doing it, but that's a hard one just because there's a lot of money with it not being covered by insurance, and some people are out to make money off it basically. Hyaluronic acid, this is known as a gel shot. Very common in knees, actually works pretty well in knees. I don't know if I've ever seen it work in a shoulder. We'll sometimes try it out of desperation, but the recommendation is pretty strong that it doesn't really work. So it's probably not worth your time. That's my
Yep. So I'll pick it up now. So now we'll talk about surgery and we'll get into kind of the surgical management after the non-surgical management. So the first question is when surgery is right for me. This is a patient by patient choice, and normally the saying is that you'll know when the time is right. A shoulder replacement is an elective procedure. There's nothing scary or urgent about shoulder arthritis, but it comes down to how bad your symptoms are, whether it's affecting your quality of life and the things you want to do, and what you want to do about that. So now we'll get into some operative management. So we'll start off with the CAMP procedure. That stands for comprehensive arthroscopic management. There is basically an arthroscopic surgery for shoulder arthritis, which is a clean out. We'll talk about that, but there is a non-arthroplasty option, and then we'll talk about some preoperative planning, some cool stuff that's relatively new in the shoulder world when it comes to shoulder replacement, and then we'll dive into the different types of shoulder replacements. So the CAMP procedure means comprehensive arthroscopic management. Basically, this is just an arthroscopic clean out of the shoulder for people with mild to moderate arthritis, with the idea being that this is just the goal is to kick the can down the road. This isn't a cure for the arthritis. This is just hopefully improving the function of the shoulder for a short period of time, or hopefully a longer period of time, to delay the need for an arthroplasty. So again, the goals are to decrease pain, improve function, and hopefully kick the can down the road. And appropriate patients. So patients who are, active, have high demands, who don't want to be limited by the restrictions of a shoulder replacement, and who, most importantly, understand that this won't be a cure. The idea is basically you do an arthroscopic surgery to just clean out anything that needs to be cleaned out and address any pain generators in the shoulder, whether it be loose flaps of cartilage, some bone spurs. If the biceps tendon is inflamed, you can take care of that. Clean out any bursitis or any bone spurs that are digging into the rotator cuff. These are the original results from the guy who kind of coined this term. On his studies, it was pretty good. There are some predictors of failure. Basically, you still have to have some joint space left, meaning there has to still be some cartilage left in the joint, and you can't have any significant wear and tear, which is really more stuff for us to consider when looking at the X-rays. And now this kind of just shows that this is a study of multiple studies showing that the results that I just showed you on the previous slide have never really been duplicated by other people, and basically the amount of relief and duration of relief is pretty variable with this procedure. So next we'll get into kind of the more arthroplasty stuff. There's this new software technology that which we can use for preoperative planning. The idea being that we get a CT scan of your shoulder, which a CT scan, for those who don't know, is like a three-dimensional X-ray. And then we upload that into preoperative planning software, and we can come up with a 3D model of the shoulder to kind of look at the humerus and the glenoid in 3 dimension and plan out the surgery. It's particularly useful for looking at the socket because there can be a wide variety of socket deformity that we have to deal with and plan for when considering a shoulder replacement surgery. So we can plug it in and then come up with that model of your shoulder, show basically what the socket looks like now, look at the pre-morbid anatomy, basically where your joint line used to be before there was all the wear and tear in the shoulder, which can help us balance the shoulder. And then we can place the components in the computer model to basically just help us have a game plan when coming into surgery. So now to talk more about actual shoulder replacements, the surgical incision is on the anterior or front of the shoulder. It can range in size. It's normally like about 10 to 12 centimeters, maybe a little more. And we do what's called the deltopectoral approach. We basically, exploit planes in the front of the shoulder to get down to the shoulder joint. So now I'll talk about an anatomic shoulder arthroplasty. So basically for an anatomic, now we're starting to get into the different kinds of shoulder replacements. The shoulder's a ball and a socket joint like we discussed, or a golf ball and a golf tee. So we replace the arthritic socket with a plastic socket and the ball with a metal ball. The main things that we need to make sure are when considering an anatomic are that you have a good rotator cuff, that the rotator cuff is still functioning because that's what keeps the shoulder centered in the joint, and that there's adequate bone stock where there's not too much wear on the socket side because we have to be able to properly implant that plastic socket. And now when doing the approach for a shoulder, we do take one of the rotator cuff muscles off of the front of the shoulder. The one in the front is called the subscapularis. These pictures just show there's a couple different ways to manage this, a couple different ways to take it off the front of the shoulder, but the important thing is that it's always repaired on the way out. It doesn't matter which way you do it as long as we get a good repair, which the Academy states. And this is why it's super important to be compliant with your physical therapy regimen because the subscapularis muscle has to heal in order for an anatomic total shoulder replacement to work well. This is just kind of some more stuff just to illustrate, there's a wide variety of the ways that the socket can be misformed, or there's a lot of ways that the shoulder can wear to produce basically different types of socket morphology. Again, this is really more for us, just showing you guys there's a lot of things to consider when considering a shoulder replacement, and all of these factors are things we're thinking about when deciding if someone, might be better served with an anatomic shoulder replacement or perhaps a different type of shoulder replacement. And again, this is kind of diving into the weeds. Like I just said, we now have more options for that plastic socket for a shoulder replacement, which is one of the reasons, we have new technology, which is why shoulder replacements have been on the rise in the recent past, as we previously discussed. In terms of the replacing the ball, historically we used big metal stems, but now there's been a trend towards the stems getting smaller and smaller and smaller, and now we all use stemless components, which basically make the surgery faster. It's less surgical trauma. It leads to a better recreation of anatomy and reduces implant related complications. And then just to kind of round it out, as I discussed previously, on the way out of surgery, we repair that subscapularis muscle And again, very important to listen to the physical therapist and be compliant because this has to heal for someone to have a good result with an anatomic total shoulder.
All right. So I will continue on with our portion of the surgical management of shoulder arthritis. And now we're moving on to reverse shoulder arthroplasty or reverse shoulder replacement, which is a term that's becoming very common and that many people will hear about before they even come to the office and ask what the difference is. So why is this becoming so much more popular? Why are people asking about it? It's the newest kind of how we replace shoulders. It's a much more young operation. So it was first FDA approved in the US in 2003. So it's now been around for 22 years, which is a very short lifespan in terms of arthroplasty. Shoulder arthroplasty has been around actually since the 1950s, and hip and knee arthroplasty even longer than that. And this was developed because shoulder arthroplasty cannot manage, or traditional anatomic shoulder arthroplasty cannot manage all of the different types of pathology we have in the shoulder. So there was a lot of people that prior to this, we could not help and make them better. And so this was initially thought of back in the 1970s and 80s, and the most popular person to think about this was Paul Grammont, and developed a prosthesis that actually worked. The ones earlier in the 70s really had high complication rates. And this Grammont style prosthesis is the kind of the old way of doing it, and we've kind of moved along now. But basically, the idea is that you put the ball where the socket was on the glenoid, and you put the socket where the ball was. And in doing that, you create a more stable articulation. In a shoulder, naturally, our rotator cuff, even though they're muscles, they're a dynamic stabilizer for the shoulder. So they improve the stability, and they turn that golf tee, or I like to call it a dish, so that the shoulder is a ball and socket joint, as Dr. Smart told us, and it's like a kind of a golf tee. I call it a dish, and so it's inherently very unstable. And what really turns it into a socket is the rotator cuff. So in all the people that have rotator cuff tears that are not fixable or have rotator cuff tears and arthritis, if you were to do a traditional anatomic replacement in those people, that shoulder replacement would be unstable. It wouldn't be necessarily a strength problem, but that would cause it to be unstable and cause it to fail early. And this is now a more stable articulation that can give you stability and allow your deltoid to work. So now that's available to us for people with rotator cuff tears, it's kind of expanded quite a bit, and a pendulum swing has occurred where majority of replacements these days are reverses. There's a lot of debate out there whether it should be the majority, but there are people out there that will do a reverse for everyone just because it takes the thought out of what they have to think about for their patient. So how this works, we talked a little bit about it. Obviously, in general, the initial concepts was you medialize the center of your rotation and distalize the humerus to create a different moment arm for the deltoid to work. There's a bit of a change and a shift in that as well. I think we're tending more and leaning more towards implants that lateralize our center of rotation a bit to make it what we call more anatomic. But that center rotation and the deeper socket allows the deltoid to do the work for the shoulder. And it can be variable in terms of the amount of motion you can gain back, and rotational motions, rotating your arm out and inward, can be variable in this scenario, depending on what type of, how affected your rotator cuff is. So why do we do this procedure? Like we talked about, the most common, or the original indication for this procedure is rotator cuff tear arthropathy, or folks with massive rotator cuff tears that have an unrepairable tear. So there are times over time, as your rotator cuff tear sits there and gets worse, it can become unrepairable as it retracts and atrophies. And we can't fix that arthroscopically. And patients that have pain and dysfunction from that can be improved with reverse shoulder arthroplasty. These indications have broadened recently, and this has become a very common way of dealing with proximal humerus fractures. So proximal humerus fractures, when the bone breaks around the ball, many times that can be treated non-operatively. Sometimes we will operate on that if we think we can improve your function by lining up the pieces better. And there are other times where that's considered maybe unreconstructable, or given the patient status or previous shoulder function, you might treat that with a reverse replacement. The reason why that's happened is because you then don't have to worry about the bones around the rotator cuff healing as much as you do with a standard replacement. So you can get better outcomes with that. And then revision replacement. So when your shoulder replacement wears down eventually, right? This is not a cure for arthritis, but the longest term solution we have. These should last many years, but when it does wear down, oftentimes it's much more rare these days to do a second replacement as an anatomic replacement. Most of your revision surgery will be done with a reverse replacement, as oftentimes you have significant bony deficiencies in the socket, which make it hard to get the traditional cemented socket back in place. And using this metal device with screws can give us better fixation. And so that kind of leads into people with just arthritis and not rotator cuff tears. Why do we do reverses in them? That can be, as Dr. DiStefano showed, those pictures of the different types of wear patterns on a glenoid. If you have really bad bony socket wear and you can't get a traditional plastic socket in a good position, or to get the joint line back to where it needs to be, that's where you can utilize this as well. And that's why this pendulum is kind of swinging towards reverse in the recent years. And I talked a little bit about the design changes. So we've kind of shifted away from the Grammont style replacement to one of a more lateralized glenosphere, which can improve motion, especially raising your arm, and it gives better tensioning on the remaining rotator cuff muscles, which can help with rotation as well. There's a problem early on with these medialized reverses where the socket would actually bump into your scapula bone and cause bony wear and loosening over time. So that's improved by lateralizing the glenoid, and this also improves stability of the joint. And then there's variations in how the sockets are done as well on the humerus. So you have different neck shaft angles. So the different angle of the socket moves your arm up or down in space and changes how much deltoid, or changes the pattern or the force vector of your deltoid and any remaining rotator cuff muscles you have. But it's felt to give you a little bit better deltoid tension, whereas a more anatomic neck angle, now we think that restores the anatomy better, certainly decreases impingement and notching, and gives you better motion and potentially better stability. Lastly, shoulder hemiarthroplasty. So this is now going almost a bit backwards in time. When we first started doing shoulder replacements, long before any of us were born, we weren't replacing the socket. We were just replacing the ball. And that carried on for a very long time and is still an option today. However, in patients that have arthritis on both the ball and the socket, they won't get as long-lasting pain relief from this operation. Patients where we will still do this, or patients more commonly that we will still do this, is folks that actually have an arthritic problem only on their ball and not their socket, such as avascular necrosis. That's a problem where your bone dies and you get some collapse of the bone and you have an incongruent ball. By replacing the ball, if they still have a good socket cartilage, you don't need to replace the socket. Those are very good. And then there are some folks that are still using hemiarthroplasty in high demand patients. There are young, heavy weightlifters. I think there's a little bit of a change happening in that right now. We have some different socket designs that may be able to sustain those higher forces. But the reason for doing that is to hopefully avoid a socket problem in the future, or at least give you some time before you need to have the socket operated on. And so you won't have necessarily as good a survival over time from this, but it might buy you some time if you're younger. And when do we do a reverse replacement? When we have regular arthritis and an intact cuff. It depends a little bit on the patient. It depends a lot on the anatomy and what's happened. In certain scenarios, if you feel somebody maybe has a low functional demand or has a rotator cuff that's intact but might be weak, this may give you a better option for better survival and better stability of your implant. And where we do a lot of our surgeries now is at our surgery center. So this has transitioned over the past few years to mostly an outpatient operation, both anatomic and reverse shoulder arthroplasty. So most people can come in and go home the same day from surgery. which is very nice. I think it's always nicer to be in the comfort of your own home. The pain relief from this operation is fantastic. So you really have very little pain once the arthritis is out of your shoulder. And having it in a specialized center like this certainly decreases risks of complication, infection, and whatnot. And obviously, there are scenarios we'll be still doing them at our local hospital partners in Krause and St. Joe's. Post-operatively, the majority of us will keep our patients in a sling for about 6 weeks. And the reason for keeping you in a sling is to protect that subscapularis repair. Even in a reverse shoulder arthroplasty, we can repair that afterwards, and it can potentially help with stability and range of motion. So we try to keep you protected for that first 6 weeks. Various ice devices such as the Game Ready or some other polar cares that we have here that can be purchased help with keeping the ice on your shoulder and help with the postoperative pain. Generally, you can sleep any way you want, but oftentimes patients find it easiest to sleep in a somewhat upright. So using a recliner is often a good technique at first to see how you're doing. So it's certainly okay to be active after surgery, but you have to follow those protocols with the sling. Generally, you're going to be starting to see our therapist right after surgery within a couple days, and they're going to start some gentle motion and stretching on you. And you'll be doing stuff at home every day. It's really important to do your stretching because if you don't stretch, you're not going to have a good outcome. But if you follow the rules, you'll have a great outcome at 95 or more % of the time. Usually you have some sutures that might be removed after 10 to 14 days. And you want to be sure that you think about this ahead of time and how you're going to manage, especially if you're limited at home or by yourself, how you're going to manage your meals, freezing them ahead of time so you can just throw in a microwave and getting some clothes. There's a lot of really cool things on Amazon where you can have Velcro or snaps on the top of your shirt so you can just Velcro it on and off, and it's really makes it easier to get dressed. And so our post-operative, protocols really focus on getting your shoulder moving so it doesn't get stiff, but protecting that subscapularis repair. And so we have really well-defined protocols that you follow along with us and the therapist during that time. You don't necessarily need to go to the therapist a lot. You can do a lot on your own, but what's most important is that you're following those protocols. So if a shoulder gets stiff, it becomes painful. So this is why we do this. You'll see early on, it's just little pendulum swings for your arm. All of us may have little different types of protocols, but we advance it as we go along at the 6-week and 12-week marks. We generally don't recommend driving while you're in a sling. We don't want you to be driving with your arm out of the sling when you're supposed to be in a sling because that can overstress your replacement and your repairs. And if you're in a sling, you're at a much higher risk of an accident. So that's a big one and one to really think about how to get around it. It's 6 weeks. It feels like a long time, but it's really short in the grand scheme of things. And obviously getting into heavier activity will be a bit longer, but most of us will release you to generally full activity in about 3 months. And there's a lot of information on outcomes and how we do after replacement. But the thing you should notice is that you should expect to have very excellent pain relief and return of pain function and motion. And that generally happens the pain relief is almost immediate, and the function and motion happen very quickly. Most people will say they forgot they had the replacement done after about 6 months, but it's a 95% chance of success with this type of surgery, and they tend to last quite a long time. They can last 15 to 20 years if you treat them appropriately. Reverse shoulder arthroplasty as well has very good outcomes. There's a lot of different data out there. Generally, the thought is that you'll have a little bit more natural motion and potentially more greater endpoint in motion with an anatomic replacement, but both of them absolutely improve motion, function, and pain. And I'll hand it over to Dr. Battaglia to talk about the registry.
Sure. So this is just kind of the wrap up to talk a little bit more specifically about how folks with shoulder replacements do, and more specifically how our patients with shoulder replacements do. So What a registry is it's basically a database of joint replacements, and sometimes they are just those performed by one group. There's some national registries that include data from thousands and thousands of groups. But SOS maintains our own registry, so we can sort of track our successes and see how our patients do. We started this for shoulder replacements a little over 2 years ago. And we track both the anatomic and the reverse replacements that were just spoken about. And we also track the revisions, which means where something in a shoulder wore out, went wrong, fractured, and it needed to be redone. And that would include both revisions of our own shoulder replacements and also revisions of shoulder replacements performed by other surgeons who then come to us for the second procedure. We look only at elective surgeries, as Dr. Everding stated. Sometimes we do these shoulder replacements for fractures and other more emergent issues. That's sort of a different patient population, so those are not included in the registry. And we do our best to follow these patients for a pretty long time, right? Patients can do well for a year, but not be doing great at 5 years or 10 years. So the longer we can track these patients and get data, the more valuable that data is. And in terms of the data we try to get, there's various measurement tools, which are not all that important that you know the difference on them, but they track things like your pain score, how you feel about the joint, your function with objective measurements of your range of motion and such things. And all these things go entered into our registry. So in the 2 years or so that we've been doing this, we're getting close to 1,000 shoulder replacements, which, you know, sort of tells you how many of these we do. We're a very busy shoulder surgery practice. Great majority of these, almost 95%, were done as an outpatient procedure, meaning they did not spend overnight in the hospital. And as you would expect, the great majority of these were primary replacements, meaning the first replacement a patient had, not a revision or a redo. And in terms of how many patients we actually got to fill out this data and give us some information, almost all patients gave us at least one data point. We obviously try to get surveys at multiple data points throughout those 15 years, but we got at least some data from nearly every single patient. So one of the measurement tools we use is called the visual analog score. And this is just really a pain measurement score or scale. And the absolute numbers aren't that important, but as has already been mentioned, probably the most reliable prediction you can make for someone getting a shoulder replacement is that it's going to greatly improve your pain. And you can see that, you know, within just a few months, pain scores had dropped to 1/3 and actually continued to trend down a little bit all the way to a year point. So this is on a 10-point scale. Most people are giving their shoulders an under 2 out of 10 pain grade when they're a year out from surgery. Another measurement we use looks at the function. And so here, the bigger the numbers is better. This is on a 100-point scale. And again, not to get bogged down in the details, but if you compare the pre-op score to the 1-year score, functional score has basically doubled, 36 up to 73. And again, these are just SOS patients. These are reflective of the shoulder replacements we've done here at our facility by our physicians. This is a score that sort of combines pain and function. Again, doubles 39 to 79 within a year. I think the other important thing to see from these graphs is you make a big improvement early, but you continue to get a little bit better and a little bit better for a while after surgery. So it's very important when you go through a shoulder replacement, or really any joint replacement, to expect continued improvement. You're really not going to level off until probably a year after surgery at the earliest. So have little problems at 3 months or 6 months, the typical advice is stick with it. It's going to continue getting better. If you just sort of ask patients, are they satisfied? Are they happy they did this? Again, you can go through the thing. Pain reduction, 90% got as much or more pain relief than they expected. Motion and activity abilities, both ADLs, which stands for activities of daily living, as well, even sports activity, very high expectations. Now no surgery we do is going to reach 100%. But if you compare these data to sort of national data and those published from some of the other centers, these are as good, if not better results than some of these other places. People like to ask about complications. Out of that 780 surgeries or so, 5% had a complication. Nothing to ignore or to minimize, But again, compared to hip and knee replacement surgeries, shoulder replacements have a significant lower complication rate. And when you dive into those complications, the great majority of them are things that did not require additional surgery or could be managed with other non-operative things. The big ones, a fracture. Now, some of those can actually occur in surgery when you're pounding in these pieces and drilling and implanting these things. Afterwards, fractures around the metal can occur, and they might or might not need surgery. The next two, dislocation or loosening or an infection, those are typically complications that are going to need another surgery. But add them all up, it's less than a 5% chance. And fractures around the shoulder can occur in various regions. They can occur on the humerus where the ball has been replaced. They can actually occur on some of the supporting structures around the shoulder because the way the shoulder is realigned, particularly on a reverse replacement, tends to alter the stresses on some of those bones. And so sometimes they react with a stress fracture or other injury. So there's a number of fractures that can occur after surgery, but very rare. 18 total fractures out of 780 shoulder replacements. When you get to the revisions, just by definition, a revision or a redo of a previous shoulder replacement is a significantly more complicated surgery. Not only are you dealing with scar tissue, you're dealing with possible infection, you're dealing with loose components, you're dealing with difficulty in removing the old implants and having to get new ones well seated on bone that might be compromised. So typically you don't expect quite as good a success rate or scores for your revisions. But even with those things in mind, our revision rate was very low. Less than 2% of our 800 shoulders that we've done so far have had to come back for revision. And again, the reasons for revision are there's a number of them, but you'll notice that there's not really any one main bullseye or main concern here. A couple for loosening of the implants over time. 3 infections out of 780 surgeries is an incredibly low infection rate for joint replacements, and then some combinations of fracture and some other things. So that's just sort of a wrap up of our individual rates. I think it's going to be opened up to questions now from folks.
Do we have any that are getting put through the chat or hit these first?
But I think if we want to start with, there was a number of folks that sent in questions when they registered, and greatly appreciate that. It helped build the presentation, and really we have a forum here of our shoulder specialists, and we're hoping you can look through them and answer. I know we probably can't get through every question, but some of them.
So I think one of the ones up on the top of the list is how long does a shoulder replacement last, and is there an age replacement? I kind of put these two together oftentimes in the office, especially talking to the younger patient. We would generally expect a shoulder replacement 80 to 85% to last 15 to 20 years. So this can be a very long operation. And that's data from replacements that were put in the 70s and 80s. So hopefully we're doing even better than that these days. And so that's what you can expect, obviously following some basic rules. I don't tend to put a specific weight restriction ever on anybody anymore, but it's more of depending on how you use it is how long it lasts, right? If you drive your car really fast and you slam on your brakes a lot, your tires and your brakes are going to wear down a little quicker. Same with this plastic piece in the shoulder replacement. And therefore there's not really an age limit, but you have to understand what age means for you and what that means down the road. If you're young, and you have a bad problem in your shoulder, you should absolutely have a replacement. But you have to understand that means likely on down the road, you'll probably need a second replacement if you're in your 40s or 50s getting a replacement. It's certainly on the very young end of when we do this. Most people are in their 60s and 70s, but I wouldn't tell somebody that has failed non-operative management, injections aren't helping, anti-inflammatories aren't helping, therapy's not helping. We wouldn't tell you to wait 10 years so that you're 60. We tell you to have it done and enjoy those years, and on the backside, we'll fix it again if we have to.
I'll answer this one off the top. Can shoulder arthritis radiate to other parts of the body? For example, the shoulder blade to chest and front. The short answer I'd say is absolutely yes. As Dr. Smart described, the shoulder is made up of a couple different joints. There's the glenohumeral joint that we're talking about with shoulder replacement, but also the scapulothoracic joint, which is the shoulder blade as it moves on the chest. And for someone who has arthritis and less motion in the glenohumeral joint, they can try to compensate by moving more through the scapulothoracic joint or, the other joints in the shoulder, which can lead to overcompensation and pain and symptoms. So the short answer is yeah.
I'll take the next couple. So 5, 6, and 7 kind of go together as far as what treatments can help relieve increasing shoulder pain. I mean, there's too many to kind of discuss here. I think previously in the kind of slides, we talked about, it really depends on what that pain generator is. Is the patient presenting with us with a mobility deficit? Is there a strength deficit? We're going to take a look at all of those things. And our number one goal, not even just with an arthritic shoulder, but somebody who presents just with general shoulder pain, we're going to look and see, is there a mobility issue? And that's always what we have to resolve first, is to kind of alleviate that mobility deficit and then look at what presents itself with our strength issues. And then we kind of jump down to, best exercises to build strength in an arthritic shoulder. Sure, we want to increase range of motion. We want to take a look at, the current function of the rotator cuff, but we also take a look at posture and the postural kind of muscles, meaning the muscles between your shoulder blades. And we work a ton on that initially before we start getting into a ton of rotational exercises, because we're going to look to find that happy balance as far as, helping with the symptoms. But we wish we had that magic wand to make the arthritis go away in physical therapy, but we're not going to alleviate the arthritis. We're going to alleviate the symptoms that are presented.
I'll quick tackle the next section, which were a number of questions that Dr. Smart sort of answered most of them already on non-surgical alternatives. As he said, the PRP and stem cells, which come under that biologics category, there's not a lot of side effect or risk to doing them, but they are not covered by insurance, so they're both relatively pricey treatments. And as the medical literature stands right now, there is really no conclusive evidence to state that they're going to give you any sort of long-lasting relief, and they're certainly not going to accomplish regrowth of the cartilage or actually any cure of the arthritis. Similarly, the gel injections really have very little role in shoulder arthritis. These other things that ask about can natural supplements, arnica gel, ibuprofen help with arthritis? If by help we mean lessen the symptoms to a degree, then they certainly can. If we're talking about actually fixing the arthritis or solving the problem on any sort of permanent or structural basis, then no, they don't have any ability to do that. And then finally, someone asked whether marijuana can help alleviate pain, and if so, is it something prescribed? Marijuana certainly has, a number of studies showing its use for chronic pain syndrome and chronic pain issues, including orthopedic pain. It isn't something that we prescribe here at SOS, and my personal opinion is something like that would really be more for the patient who requires chronic pain management because they don't have any other options. If you were an appropriate candidate and everything else had failed to alleviate your arthritis, but a replacement was a appropriate and recommended treatment, that I would certainly be considering that more than I would be considering going on a chronic marijuana regimen.
I can answer some of the questions. People had a lot of questions about exercise and shoulder issues. And one of them was talking about weight training. Can it aggravate or help a shoulder issue? It definitely can help, but you just have to be careful. Heavy weightlifting, heavy bench press, overhead press can certainly put a lot of stress on the shoulder. And a lot of patients that do that for a long period of time can end up with shoulder arthritis and a rotator cuff tear. So there's definitely a balance there. Can exercise help me after a rotator cuff tear? It can, because you're trying to improve motion and strengthen all the other muscles around the shoulder. You just have to be careful, because if and somewhere else in here I saw do rotator cuff tears ever heal, typically a full thickness rotator cuff tear will not heal. The muscle and tendon are kind of tension loaded, so when the tendon detaches, it pulls away from where it's supposed to go. So you want to rehab it and get motion and strengthen all the muscles around it, but that particular tendon most likely is not going to really heal itself. What exercises can help alleviate arthritic symptoms? Again, it's a fine balance where you don't want to overdo it, because you're going to probably make yourself hurt more, but certainly keep in range of motion, keep in strength. can keep the shoulder good for a longer period of time. Because there's many patients we'll see that'll actually have pretty significant arthritis, but have almost full motion and strength because through the years they've kept that. Whereas if you lose that motion, it can be a problem. Building strength, again, that goes back to the physical therapy of strengthening all the muscles around the shoulder, namely the rotator cuff muscles, but also all the muscles that stabilize the scapula. They're hugely important. And then the last one was a good question, says how long is the recovery for a replacement versus a rotator cuff repair? And replacements are faster, as you saw in the numbers where people improve. A lot of replacements by 6 weeks to certainly 3 months are in a pretty good place. 3 months, certainly, with a pretty functional shoulder that we don't worry about a ton. Rotator cuff surgery can take longer. By 3 months, you hope the tendons have healed, but by then you're really just beginning the strengthening program. To get back to physical work with a rotator cuff repair can be easily 5 to 6 months.
And then there's that kind of bridges us into a section on questions about recovery and some surgical questions. One of which is replacing both shoulders and how long do you have to wait for getting injections. Most of us would recommend if you're going to have a replacement shoulder or elsewhere that you haven't had an injection in that specific joint for at least 3 months. And there's some really good data out in the literature that the longer that can be, the better. And the rotator cuff literature that there's even a higher complication rate with an injection within a year of that surgery. So the longer you can wait, the better from a cortisone injection. When it comes to getting both shoulders replaced, people will ask often how long they have to wait for their second shoulder. What you'll see in the recovery data, there's some really good data on speed of recovery. And you'll see that in that data, and it's highly dependent on the postoperative protocol as well, but people will have gained about 80-ish to 90% of their motion by the 3-month mark and about 96 to 98% by the 6-month mark. So I usually will have people wait till their 3-month post-op. And if they're doing really well and they think that they can manage their daily activities with their newly operated shoulder at that point in time, then I think that's the time it's safe to start planning and booking their other side. So usually the quickest turnaround is going to be 4 or 5 months from your initial replacement before your second one. And then again, with that length of recovery, I think you'll see in some of the stuff that was presented already, you'll gain a lot of motion by 6 weeks, certainly 3 months and 6 months, but you'll be continuing to improve for a year and longer sometimes. And then lastly, somebody did ask if they got shot in their shoulder and it only lasted 5 days, is this normal? If you have really bad arthritis, that's when injections can start failing. And we would expect a successful injection to give you close to 3 months relief. And so if you've only gotten a short period of time relief, that's when we start to think that that's not a good option or treatment for you. Granted, the injection could maybe have not gotten in the joint or gotten in the wrong place. So it depends who gave it, how it was given, and where it was given. And so those are things we can certainly talk with you about in the office.
We have some more questions. We'll jump out. What functional measures do you use to help determine severity, and how much does that sway your judgment? We went over our registry data, multiple functional kind of patient-reported outcome scores to help us kind of quantify, the amount of pain and dysfunction you're having, and then that helps us kind of track how much our patients improve after shoulder replacements. What materials are used for the replacement? So the plastic, highly cross-linked vitamin E polyethylene and metals, a combination, cobalt, chromium, titanium, things like that. Is it possible to determine if shoulder pain is osteoarthritis or rheumatoid arthritis? The answer is yes. Going back to what Dr. Smart said, we don't see that much rheumatoid arthritis anymore, but it's just a different wear pattern you see on x-ray. So sometimes it can be pretty easy to determine, but there are also laboratory values and things that we can do to help clue us in that it might be rheumatoid arthritis, all things we consider when determining what type of shoulder replacement might be best for a specific patient. Is there a weightlifting limit forever post-shoulder replacements? I think this is surgeon dependent. The best answer would be yes. No, any heavy overhead lifting will just cause more wear on the ball and the socket and lead to, faster, wear and potentially wearing out the shoulder replacement. But, it's a patient by patient thing where they want to get the shoulder replacement to do the things they want to do. And if they understand those risks and accept them, then, they can do what they want to do.
I did skip over a question in the recovery section about if a rotator cuff tear has been previously repaired, can it be repaired again, or do you have to have a replacement? Absolutely, rotator cuff tears can be repaired at another time or even another couple times. Your rate of success is going to go down every time. So a lot of it will depend on you, your age, your comorbidities, what your torn tendon looks like, maybe what it looked like at the time of surgery the first time as well. And then obviously ultimately a lot of it is patient choice based on our what we can give you as an assessment for success from that surgery versus a reverse and age and everything else that goes in with it. Somebody's got a hand raised.
We have had a number of more questions.
Sure.
Come in. If got a few more minutes here. What is used for pain relief after?
So those protocols have advanced quite a bit, and we've the most important thing is a regional block that you get before the surgery. So you get an anesthetic in the nerves as they're coming out of your neck above your shoulder. It numbs up your entire arm for about 12 to 24 hours, and that gets you through the worst of the surgical pain without having any feeling of it at all. So that makes a huge difference. We do a lot less with narcotics these days. Most of us probably only give one small script initially, but I would tell you that the vast majority of people state they took them the first day or two after surgery and then realized they didn't need them. For people that can take anti-inflammatories, we usually do a prescription strength or high dose anti-inflammatory that we have running for the first, at least for the first couple weeks after surgery. And actually standing Tylenol does a really great job as well if you take it standing every 6 hours.
Got a question. How common is it for the body to reject the components of a replacement?
Pretty uncommon in general.
Very unlikely. If you have a very well-defined metal allergy, then that's something to bring up at your appointment. Most people it's nickel, but there can be other ones. So if it's quite severe, you might need to have allergy testing because there are other different alloys in these replacements. And if you have something quite rare, you have to be really careful with that. But for the most part, even a minor, cheap jewelry allergy is not something that's going to be affected by a replacement.
We did have a couple people ask about soft wave laser therapy. Sounded like it was something possibly prior to surgery. Is that something?
Yeah, it's kind of a modality that you might be able to find with a chiropractor or therapist and whatnot. We don't offer it in our therapy.
No.
I would
even know what it is.
I do. Yeah. We kind of played with the unit for a little while. We had it in clinic and, kind of had it, we were trialing it with some patients and then using it in conjunction with patients post rotator cuff repair and didn't really see any significant improvement with it. It is FDA approved, but it's not covered by insurance. So that was really kind of the big derailing, is that it wasn't something that patients were really interested in paying for out of pocket. And then without us really seeing a significant improvement in, function and pain, it wasn't something that we really felt that I wanted to tell patients they needed to pay for out of pocket. So yeah.
When it comes to alternative therapies, things like that, acupuncture, most of us would say, hey, if they make you feel better and they help, that's great. None of them are proven to make your arthritis go away, and there's an out-of-pocket expense that comes with it. Absolutely, massage therapy, acupuncture, anything else that you can think of, if they make you feel better, go for it.
Okay, we're gonna do one more question because I really want to know. Are a majority of the shoulder replacements being done on your shoulder that is your dominant shoulder, or do you know?
I don't know. We could probably pull the registry to check that out.
It is not, I mean, a lot of dominant shoulders run into more problems, but then a lot of people have bad arthritis in their non-dominant side.
Yeah.
Yeah.
I bet you it's pretty close to 50.
Yeah, I'd say it's very.
I think it depends on the younger years in sports too. the baseball players doing, overhead, you'll see, I think them have more arthritis in that shoulder, but the average person, you're kind of using both.
Well, we want to thank everybody for coming. We want to thank
Yes,
all of
absolutely.
our shoulder specialists here, and we hope you all have a great evening.
Absolutely. And if you have more questions, come see us in the office. We'll be happy to answer them.
You guys have a good night.
Have a good night.
Good night,
Thanks.
everybody. Thank you.